Start off with the introduction. We all know that there are two types of valves, biological and mechanical valve. Mechanical, in the old age, there used to be the caged ball valve, but no more it is being used. Then the bileaflet and the single tilting disc. We'll see the examples of each of them. Again, with biological valves, it can be stented or stentless. The stented valves can be either porcine, bovine, or pericardial. Likewise, in the stentless, we'll see examples of each one of them. So, just to brief it up, valves from A to D are mechanical valves, and E to E onwards are biological valves. So, the main difference is A is the traditional, no more used Star Edwards caged ball valve, and B is a Jog Shelley's tilting disc. B and C are both tilting disc, both are from different manufacturers, and D is the one that is commonly used, St. Jude's valve. E and F are porcine valves, and they are one of them is stented, another one is stentless. The valves preceding them are the ones that we use during the TAVI procedures, and depending on whether they are supraannular or annular, they are further classified, and there are other examples of as described in image. So coming to the topic, the assessment always begins with the clinical information, followed by the imaging modalities, whether the screening echo is showing any abnormality. After that, we can go ahead with the Doppler evaluation, and lastly the supportive findings on echo, as well as sometimes we can use CT and cine fluoroscopy as well to further evaluate the prosthetic heart valves. So each one of them has got an importance. So what is the date of valve replacement? As we will study in the future slides, that when we are not sure clinically or echocardiographically whether there is pannus or a thrombus, then the date of valve replacement, usually pannus is seen after some years after, so it's a degenerative process, so it will be seen after some years, whereas the thrombus is usually an early presentation. For bioprosthetic valves also, degenerative prosthetic dysfunction can be assessed by roughly by knowing that what was the date of valve replacement. Then another important parameter is height and weight, and with which we calculate the body surface area. We'll study further that if the valve that is implanted, its EOA or the effective orifice area is less than the indexed EOA, that is EOA divided by the body surface area of that individual, then that individual carries a risk of patient prosthetic mismatch, that and the complications related to the patient prosthetic mismatch, which we will study in the next slides. What is the blood pressure and heart rate? The blood pressure and heart rate further plays an important role in knowing the Doppler indices. So if the heart rate is very fast, and at that point of time if we are using the Doppler parameters, then there can be minor errors, so they should always be known. Plus, if the blood pressure is very high, let's say if we have an AV aortic valve replacement and the systolic blood pressure is high, then the gradients across the valves can be falsely low, so it is important to know the blood pressure. So the date, the type of valve, the whether what symptoms the patient has come with, the body surface area, as well as the blood pressure and heart rate are important parameters in the clinical assessment. Then we begin with the actual evaluation of the prosthetic valve, the imaging aspect, that is just cross screening. What is the motion of leaflet, whether if it is a bileaflet valve where both the medial as well as the lateral leaflet of the valve are moving or not. They are easily discernible in the mitral valve, but not so with aortic valve. We'll study what is the sensitivity of each investigation in the upcoming slides. So the next is whether there is presence of any calcification on the leaflet and any abnormal echo densities like thrombus, vegetation, pannus. This can be seen using just the screening echo, and the as well as the whether there is any valve dehiscence. Dehiscence refers to the separation of the leaflet of the valve swing ring from the native annulus. If it is an aortic annulus, whether if the swing ring has got detached from the annulus, and whether there is an integrity between loss of integrity between them. So that those aspects can be evaluated just by using the screening and not the Doppler parameters. So once we have screened and we have found some abnormality or not, it is always better to look for the gradients across the valve. So once if there are high gradients across the prosthetic valves, then the Doppler assessment can be typically studied under following headings: that what is the contour of the jet velocity, whether it is a triangular one or a tongue shaped one, what is the peak velocity and the gradient across the valve, what is the DVI or Doppler velocity index, also known as dimensionless velocity index. So we'll study what is this. Then pressure half time, especially in case of mitral valve and tricuspid valve, not so in aortic valve. Then EOA, the one that was previously discussed, and whether there is any regurgitation, whether it is a pathological one or just a washing jet. All this will be studied in the next slides. So basically the Doppler would be in the form of contour of the jet, the peak velocity gradient, the DVI, the pressure half time only in cases of mitral valve, and EOA, and the whether there is presence of any pathological regurgitation. And as discussed, whether there are any supportive findings. Supportive findings include whether there is LV hypertrophy or not, or there is pulmonary hypertension or not, or there is LA or RA dilatation in cases of severe MR and TR respective. So we'll just brief the comprehensive echo evaluation. So it starts with the motion of leaflets or the occluder. So as discussed, the occluder is better seen with mitral valve, not so commonly seen with aortic valve, and since the opening and closing angles of each are seen in, like for mitral valve, by transthoracic you are sure that 77% of the cases you can see the motion of leaflet, and by TE 100%, but not so in aortic valve. That is because of the swing ring artifact. So we can see the sensitivities of each of them, that by transthoracic the swing ring artifact, only 13% of them we will be able to see the motion of the leaflet in the case of aortic valve, and slightly better with TE, that is 33%. So in order to comment on the leaflet motion, it is typically challenging in cases of prosthetic aortic valve because of the swing ring artifact. So if the gradients are high or the screening echo is showing some abnormality, better to go with fluoroscopy. Second is the opening angle. So that differs from that according to the type of the valve. In case of mechanical valve, if it is a tilting disc, the opening angle is usually 60 degree versus 90 degree for a bileaflet. The commonest one being St. Jude's, the leaflet opening angle is 90 degree. The swing ring, so it should be carefully assessed because it is earliest to be involved in case of infective endocarditis, and more commonly whenever there is dehiscence or separation between the swing ring and the alveolar tissue, there would be regurgitation, but it would not be so frank because it is a wall hugging type of regurgitation. And if but the fortunate thing is it is seen in only 0.1 to 1.3% of the prosthetic valves, and if the dehiscence is let's say if it is acute, then it can the patient will have a rapidly progressive heart failure and even cardiogenic shock. So for aortic valve, 15% rocking motion or the 15% separation between the annulus as well as the valve is considered abnormal, and that demands for stabilization followed by a redo procedure. Second is washing jet. So not all regurgitations are pathological. Some Most of the times this bileaflet valve have got an inherent design in order to avoid thrombus. So about 10 to 15 ml of regurgitation is inherent to the valve design. It is not related to the pathological. It is not a pathological abnormality. So bileaflet valves have got a central orifice and a two lateral orifice. Accordingly, they can have a two lateral jets and one small central jet. The central jet has to be small. If it is large, then you can consider that it is most probably it is a pathological regurgitation and needs further evaluation with TE or clinically. So, and third is, as discussed, what are the abnormal echo densities, whether there is thrombus, pannus or vegetation. So how do you differentiate thrombus versus pannus is, it's very difficult, but there are soft pointers to it, that thrombus has got a short history. It is as equally common between mitral and aortic valve, whereas pannus takes some time, which is months to years, and most commonly pannus is on the mitral. Mitral prosthetic valves are more commonly involved than the aortic valves. Thrombus will have history of non-compliance of drug, low therapeutic INR, whereas pannus usually long history, well maintained INR, patient will have no acute symptoms usually. Morphologically, it is large out of phase motion to the prosthetic heart valve, the thrombus one, whereas pannus is smaller and confined to the, most commonly it is confined to the sewing ring. The CT values, if we go for a CT, the thrombus is having less than 200 Hounsfield units, whereas pannus will have slightly usually more than 200. And talking about the hemodynamics, the thrombus will have usually obstruct the disc. Thrombus will obstruct the disc motion, and the patient will have symptoms acutely, whereas pannus may or may not obstruct the valve and usually may or may not have the symptoms related to the obstruction. Coming to the patients that are commonly referred here for the infarctive endocarditis involving the prosthetic valves, which modalities to go about according to what pathology is being suspected. So in a recent meta-analysis, the sensitivity and specificity for detecting vegetation when compared TE versus CT was 96% sensitivity and 83% specificity for TE versus CT, but that is for the native valve. But if you are if you are evaluating the prosthetic heart valve, CT is more specific as compared to TE. However, it has to be noted that if we are evaluating a leaflet perforation, TE has got more sensitive and TE is slightly more sensitive and specific than cardiac CT. But for perivalvular dehiscence, CT is more specific than TE. So which pathology we are analyzing, accordingly the modality of investigation should be focused upon. That is, if you are suspecting a leaflet perforation related MR or leaflet perforation, TE is better than cardiac CT. Right. So vegetations, again, if so the early prosthetic valve endocarditis is usually defined as a prosthetic valve endocarditis patient coming within less than 1 year, and aortic valve is more commonly involved than the mitral valve. It has to be noted that if the earliest site, the most common and the earliest site is the sewing ring that is involved in the prosthetic heart valve endocarditis. However, in TAVI it is somewhat different. Incidence is 1%, and the leaflets are the first to be involved. Rarely it involves the stents or the perivalvular structure according to the data available as of now. So if once the sewing ring is involved, it can involve the aortomitral curtain, and it can cause valve dehiscence or AR. So this is a table showing which investigations and what are the drawbacks of each one of them. So patient prosthetic mismatch we'll discuss in detail. Prosthetic dehiscence, as discussed, rocking motion more than 15% implies significant paravalvular regurgitation. Paravalvular leak, it is basically helps distinguish from the pseudoaneurysm from the abscess, the CT, the MD-CT, and as discussed, endocarditis generally, the CT is generally inferior to TE for valve perforations because it is less than 2 mm, but superior in evaluating the paravalvular and extracardiac structures. Pseudoaneurysm, again, there is a role of MD-CT or cardiac CT. Thrombus cutoff, as discussed, it was less than 200, but a cutoff of 145 is used for distinguishing thrombus from pannus with 87.5% sensitivity and 96% specificity. Halt and hem. So this is an upcoming thing in bioprosthetic valve. Usually with TAVI valves and degeneration, if there is only thickening of the valves and no obstruction, we call it as halt, and if there is restricted motion as well, we call it hem. So mostly this halt and hem, when we are suspecting, there is a role of multi-detector cardiac CT, MD-CT, and the treatment of choice is anticoagulation. So coming to the echo evaluation using Doppler parameters. So as stated earlier, so there are this can be studied in following 6 headings, that is the contour of the jet velocity, whether it is tongue shaped or triangular, what is the peak velocity. So there are cutoffs for each one of them. The peak velocity, if it is less than 2, then we are sure that there is no much gradient unless the patient has got associated LV dysfunction and the symptoms are fitting into it. And the peak or mean gradient, the DVI or Doppler velocity index, pressure half time for mitral valve only and tricuspid valves, and presence or absence of pathological regurgitation. So once we have clinically evaluated the patient, we usually so we'll start off with the aortic prosthetic heart valve evaluation. Once we have clinically seen the patient, the date and time of implantation, the type of valve, the valve morphology, whether presence of absence of regurgitation, we, as stated, peak velocity less than 2, triangular contour, peaking in early systole, usually it is normal. So however, there are certain limitations to it, that is the high output states, and contrary to high output state, LV dysfunction, small prosthesis, PPM, that is there may not be anatomical obstruction, but the valve is smaller as compared to the body surface area or his LV outflow tract. So you can have gradients, but patient may not have anatomical obstruction, or the patient has got significant regurgitation. So all these 3 are the limitations using evaluating Doppler, evaluating an aortic prosthetic heart valve with Doppler with peak and velocity and the mean gradient, that is LV dysfunction, high outflow states, patient prosthetic mismatch, significant regurgitation. This can cause considerable confusion while evaluating the prosthetic heart valve. So standalone peak velocity cannot be taken as one of the marker of anatomical obstruction. So there are other parameters, that is acceleration time, which are independent of Doppler beam angle. The normal values are as follows, that is it has to be less than 100. If the acceleration time is more than 100 millisecond, or the shape of the Doppler is rounded, or the AT by ET ratio, that is acceleration time to ejection time, if it is more than 0.37, all this points out that the contour is a tongue shaped and not triangular shape. So we'll see the echo image in the upcoming slide. But having stated all of this, even this cannot be used as standalone criteria for confirming that the patient has got a PHVT or a prosthetic heart valve stenosis. That is, severe LV dysfunction, we may not find gradients across the valve reaching up to 4 like more than 2 meter per second. So this is just a continuation of that. Next we assess the EOA or the aortic valve area using the continuity equation. We are well familiar with this. So this correlates with the gradient, but again the gradient is dependent on many other factors like LV dysfunction, high outflow state. So this entire 6 parameters have to be taken into consideration with clinical modality, with clinical information. Then only we can comment whether the patient has got a significant PHVT or not. EOA less than 0.8 for aortic prosthetic heart valve is suggestive of stenosis. However, the A1B1 in the numerator, that is LVOT cross sectional area and LVOT VTI. So the one which is LVOT cross sectional area is very important. How you analyze the LVOT cross sectional area, because if what is the ideal way? If we are using transthoracic, it is a zoomed Plax view of LVOT diameter, and if we are using TE, then it is a TE 120 degree. Because if we are so 10%, if we are committing error in measuring the LVOT diameter, it will lead to 20% difference in the EOA calculation. Secondly, when we are using the native valves, we use the inner edge to inner edge for measuring the LVOT diameter. However, when the patient has got prosthetic heart valve, we should use the outer to outer edge. You should not mistake the inner edge of the swing ring as LVOT diameter. Again, it is invalid in severe regurgitation. It can be falsely high. It can be falsely low in cases of severe regurgitation. So the most important parameter is the DVI, that is Doppler velocity index. It is, in case of aortic valve, it is the ratio of LVOT VTI and aortic valve velocity. So any DVI, if it is less than 0.25, that is suggestive of a significant, so it is suggestive of prosthetic heart valve thrombosis. And it is a ready reckoner, because sometimes there can be error in cross sectional area estimation, there can be differences in the gradient. So you can easily see that whether the DVI is less than 0.25, then we are almost sure that the patient has got prosthetic heart valve stenosis. So other supportive findings should always be looked for, that is moderate to severe PAH. If it is not there and the rest of the parameters are falling into the category of PHVT, then the diagnosis should also be confirmed once again. So this is the table showing the normal limits of the Doppler parameter, starting from Z contour if it is rounded versus triangular, peak velocity if it is more than 4, gradient more than 35 to 40, EOA less than 0.8, DVI less than 0.25, and AT if it is more than 100, then it is suggestive of a stenotic prosthetic aortic valve. However, having studied all of this, there has to be a flow chart to assess that how to go about it, starting from clinical, whether to go with cinefluoroscopy directly in a setting where cinefluoroscopy is not easily available. So how should we go about assessing the aortic heart valve? So we'll come to that, but first we'll study one important aspect, because that will be studied in the flow chart. So what is a so there may not be anatomical obstruction, still we are finding high gradients, a rounded contour. So but after cinefluoroscopy retrogradely we analyzed that there was no obstruction, but still the gradients are high. So that is that is seen with patient prosthetic mismatch. What is it? That when the prosthetic EOA is too small relative to the body surface area of the patient, then it is called a PPM. PPM is more common with aortic prosthetic heart valves as compared to mitral valves. The long-term complications there are long-term complications of PPM, which includes if there is no anatomical obstruction but the valve size is less as compared to the body surface area or is LVOT, then the patient the LV will be subjected to the high pressures and high gradient persistently post replacement. So that can lead to LVH or RVH, that further can lead to LV diastolic dysfunction and heart failure, and ultimately pulmonary hypertension. So there are specific patient subsets who fare less fare very severely in case of an established PPM, that is patients who are 65 to 70 years old who already have a coexisting LV dysfunction are subjected to high gradients across the valve, who have significant hypertrophy and LV dysfunction associated low flow, low gradient aortic stenosis, or the patient in case of mitral valve have got a severe mitral regurgitation. These subsets will fare poorly when they have PPM. So this is a short table as studied that the prevalence of PPM moderate is about 20 to 70% and severe is about 2 to 11%. And this is for the aortic valve. So as we can see that once the body mass index if it is more than 30, so patient is obese, the cutoff value is EOA divided by body surface area. As the body surface area is increasing, the cutoff is slightly lower, like less than 0.55 to be labeled as PPM for an obese patient versus 0.65 for a patient who is having BMI less than 30. So it is purely mathematical way to represent that if the patient is more obese, the cutoff has to be further lowered down to 0.55. So how to avoid PPM at the time of operation? So step 1 is to calculate the patient's body surface area according to the weight and height. Then simply multiply the factor 0.85 to the available value. So for example, if the patient's body surface area is 1.8, then we multiply it by 0.5 to get, so this should be the minimum EOA of the implanted valve. So if the valve size is less than this, it is purely clear that that patient will be subjected to PPM. There are other methods, that is using newer generation mechanical valves, supra-aortic bioprosthetic implantation, stentless bioprosthesis, or rarely used, which is known as aortic root enlargement, and TAVI over mechanical valve replacement. So as we were discussing, so what is the approach? How do we approach a patient who has got high velocity gradient, that is more than 3 meter per second or more than 4 meter per second, and the values are more than 20 mmHg, the pressure gradient across the valve, aortic valve, is more than 20. So we first see the DVI. So if the DVI is less than 0.25 and the contour is rounded, that means the acceleration time and the acceleration time to ejection time both are more than 100 or more than 0.37, the pre-specified limit, then it is very much clear that the patient has got prosthetic heart valve stenosis. But with a DVI of less than 0.25, if the contour is a triangular one instead of a rounded one, then we have made some error in assessing the LVOT VTI or the LVOT velocity. So DVI less than 0.25, rounded or triangular. On the other hand, if DVI is more than 0.3 but the contour is rounded one, that is again the values are above the specified pre-limits, then it can be a subvalvular narrowing or again an error with the measurement of LVOT velocity. If the DVI is more than 0.3 and the shape is triangular one, that is acceleration time and AT by ET are less than the limits, then we calculate what is known as the valve is the prosthetic, there is no problem with the valve itself, the implanted valve. Then we calculate the effective orifice area index, that is whatever EOA that is available, that is calculated after using the continuity equation, we divide it to the body surface area of that individual. If the EOA is less than the EOA index, that means the EOA index, if it is coming less than 0.88, then we say that the patient has got PPM, or it can be because of high flow state, depending on the clinical scenario. So for those where the table was for the aortic valve, similar is the table for the mitral valve, that is what is suggestive of stenosis. Here one added parameter is PHT, which is more than 200 millisecond, and here the DVI is calculated using the prosthetic heart valve, that is the VTI of the mitral valve divided by the VTI of the LVOT. So the ratio is not less than 0.25, it is more than 2.5, which is suggestive of stenosis. Again, this is the flow chart. So this is for the mitral valve. So if we have gradients which are more than 6 mm Hg or more than 2 meter per second, then we first see EOA by continuity equation. Coming to the right hand side of the figure, if the EOA is less than the index EOA, or there is decrease in the EOA or DVI at the follow up, then we calculate the DVI. If the DVI is more than 2.2 and PHT is variable, it is clearly a technical error. If there is no difference in the EOA or DVI, again it is a technical error, that your EOA is coming less than the index EOA. But if the DVI is more than 2.2 or more than 2.5 and the pressure half time is also more than 130, similar to the rounded jet that we are getting in aortic valve, this PHT is the one that we are getting in the mitral valve. So if it is more than that, more than 130, it is a PHVT. But if the EOA is similar to the projected EOA, that is in EOA is index EOA is less than 1.2, then it is basically a PPM. So this is about the echo evaluation. Now we come to the fluoroscopy. Once we have analyzed the echo parameters and we further want to know whether the patient has PHVT or not, to document it, we have seen a fluoroscopy, and the X-ray beam that we are using must be tangential to the valve leaflet, a view that is achieved through a technique called as in-profile projection. Now the in-profile projection varies according to the anatomy of the heart, but grossly for mitral valve we use areocranial view, and for aortic valve we use an areocaudal or aleocranial views. Again, for mitral valve areocranial, and for aortic valve areocaudal or aleocranial. So this is just an image that it was shown that one must measure the outer to outer edge, not inner to inner edge, this to this, for measurement of the LVOT diameter. So in this example you can see that this has got a when compared to figure 1, it has got a rounded shape, the acceleration time is also higher, and this has got a triangular shape. So it is 76 versus 127 milliseconds. So the gradient was so the velocity across this aortic wall is 4.1 versus 1.8. So the figure below is suggestive of a prosthetic heart valve stenosis, aortic valve stenosis. Coming to the last topic, for the bioprosthetic valves, what is HALT and what is HAM? It is hypoattenuated leaflet thickening and hypoattenuation affecting motion. So they are forms of subclinical leaflet thrombosis. So they are more common with the so they are only seen with the bioprosthetic heart valves, more commonly seen nowadays after TAVI, and it refers to the visible thickening on imaging, HALT, while HAM is HALT plus the reduced leaflet motion. And the why there is HALT and HAM, it is because of the standard chemical fixative glutaraldate that was previously used, which used to cause cytotoxicity and inflammatory response at the site of implantation. So what we can do is use, instead of glutaraldate, biocompatible coatings like hyaluronic acid or other hydrophilic polymers that can improve the leaflet surface and reduce the risk of clot formation. And if we are suspecting HALT or HAM, using MDCT imaging, then the treatment of choice is anticoagulation. So that's it about the comprehensive echo evaluation as well as the various modalities used to evaluate the prosthetic heart. Thank you.